everyone, and welcome. I am Rachel, Community Manager here at Alloy Women's Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. Today, I am thrilled as ever to welcome back to the platform Dr. Kelly Casperson, urologist, public speaker, sex educator, and top international podcaster whose mission is empowering women to live their best lives. Dr. Casperson identified the need for better resources and developed a sex education class for women that covers topics like sexual health, intimacy, mind work, and the science of desire. She combines education, humor, and candor in her podcast, You Are Not Broken, which consistently ranks in the top 10 in the Apple Podcasts medicine category in the United States, and is the author of You Are Not Broken, Stop Shooting All Over Your Sex Life. Dr. Casperson is also certified through the Life Coach School and the North American Menopause Society. And I might add that she is quoted in Vogue magazine today talking about testosterone. And she is a featured physician in the film that is premiering this weekend. Is it this weekend?
Yeah.
Yes. Sorry, my dates are wrong. Tamsin Fidel and the M Factor. So we're going to talk about that hopefully later as well. Before we get into things, I want to invite you to take advantage of today's code Casperson20 over on Alloy Women's Health and enjoy $20 off any purchase. And finally, I want to invite you to drop your questions for Dr. Casperson into the Q&A. I will facilitate those for you as we go on this hour. We are a hard stop in 1 hour. So let's get into it. Welcome again, Dr. Casperson. In your book, on your podcast, in all of your work, you discuss many misconceptions around women's sexual health, especially in perimenopause and menopause. What do you think are the biggest myths that continue to persist, and why is it important that we dismantle those?
Oh, I think the biggest myth that got me into understanding hormones was, becoming knowledgeable about female sexual health and female sexual, the ecosystem of it. How does it work? How do our bodies work? People kept saying, well, you know what happens with menopause. Well, you know what happens with menopause. And I'd be like, anybody gonna tell me? And they're like, well, you know what happens with menopause. And I'm like, no, I don't know what happens with menopause. Like, what happens with menopause? And so like, that's the biggest myth, is that your sex life automatically gets worse or it gets non-existent. And although that can be true for some, that is by no means universal. And conversely, midlife, perimenopause, postmenopause is actually more of a, I hate to use the word, but it's useful as awakening of like, what do you want? How do you want to feel? What do you want to try? Who do you want to be with? And like, it's actually a very exciting time. And if we don't address symptoms that arise in perimenopause and menopause, it can profoundly affect your sex life for the negative.
Right.
So I think the myth is rooted in a lot of people's lived experience of like, it actually can be not as great if you don't educate yourself onto like, what do I need to do to take care of mind, body, spirit in midlife?
I love that. I think of that all the time, that perimenopause in particular is this opportunity for expansion and awareness. And I think this sexual piece maybe has, as you said, been rooted in sort of being dismissed. And your work highlights that this is not so at all. So take us to the hormone piece. I guess, how do hormonal changes during perimenopause affect vaginal and sexual health? And can you talk about the role of hormone replacement as a way to address these issues?
Oh, yeah, absolutely. So I think, the first place we always have to start is defining what menopause and midlife is. Because again, I think the myth is it's a hot flash and you can no longer get pregnant.
Right.
It's a hot flash and your periods stop.
Yeah.
Right? And realizing those are symptoms of what's happening, but that's not what's happening, right? That's like a result. You not having periods or getting pregnant or having hot flashes is a result of the ovaries running out of steam, running out of hormones, running out of eggs. And because we are now outliving our ovaries, we have these profound body changes everywhere from skin to brain to bones to genitals to vagina, that happen because everywhere in our body is influenced by hormones. Hormones are simply messengers. They go into our cells, they either act on the cell membrane or they go inside the cell and act in the mitochondria and the nucleus. They're literally like keys that help unlock the full potential of our cells. And that's every cell in our body has hormone receptors. The other big myth about, midlife is that ovaries only make estrogen.
Yeah.
Ovaries actually make testosterone, which then gets converted to estrogen. But if you start off the bat and you're like, what about women and testosterone? They think you're trying to give them something that's male, right?
Right.
Because they don't understand all bodies have testosterone, just in different ratios. In women, in our reproductive years, we have about 4 times the amount of testosterone as estrogen. And testosterone starts going down long before your periods end, but you will continue to make some testosterone even after the estrogen's gone.
Can
So I
I
always
pause
start.
you for a second, just for clarification purposes? So
Yeah.
we make 4 times as much testosterone during our reproductive years. I know that some people are still wondering, are we making less than a man makes, or are we making, what are we making? And
Yeah, about 10% of what a man makes,
okay,
but it's still 4 times the amount of estrogen that you make.
interesting. Okay, thank you.
Yeah, no, it's crazy because we've gendered these hormones and
Yeah,
we've done 2 things. We've gendered them. So we put estrogen in these bodies and testosterone in these bodies. And that takes away the importance. Like men need estrogen, women need testosterone, all bodies need hormones. So we've gendered them. And then the other thing we did is we labeled them sex hormones, which is not true. They work in our brain, they're neurohormones. But when we give them the sex hormone moniker, it's kind of, sex is extra in our society, and sex is not as important as things that work in the brain. And so really emphasizing that these hormones are neurohormones, they're bone hormones. They're not, like, air quotes, just sex hormones. They're made in our gonads, which is why they got that label. But I think it really diminishes their importance when we're like, that's your sex hormone.
That's so helpful. Thank you for that. I want to kind of give you space to say a bit more about testosterone. I know there are going to be a lot of questions about it coming in. I do want to let people know that here at Alloy, we don't offer testosterone to our patients and customers yet, but maybe Dr. Casperson, you could actually amplify why that is so, that it's hard to access.
Yeah. Gender bias.
Yeah.
So gender bias and sport doping, right? What do I mean by that? So in the 1980s, there was a lot of sport doping happening, all the way up to the level of the Olympics. Why this is important to you now is that our Congress in the United States legislated the Anti-Doping Act of 1991, I believe it was. And what they did is they took a bunch of synthetic steroids, put them on a list to say these need to be controlled better because people are abusing them. And on that list got thrown testosterone, which is a naturally occurring hormone that nobody's died of at physiologic levels ever. And I would also argue just you taking testosterone will not make you an Olympic athlete. Like these are like the doping, true doping is very synthetic based.
Right.
But but you have to get rid of the stigma that this is a dangerous hormone. And so it's been put on a list of doping. And so because of that, it's regulated by the DEA. So there's different prescribing licenses that have to happen, and that's state controlled. So it's not just like other hormones like thyroid, insulin, estrogen are all hormones that you need a prescription for. Testosterone is a hormone that you also need a state DEA license for and is much more regulated. And in addition, the scheduled medications are being threatened as far as telemedicine access,
Right.
being threatened at the end of 2024. It's going to be interesting to see what happens. So
Yeah.
for that reason, for the sport cheating people, it is now more difficult for you to access a physiologic hormone.
However, if you are a woman who goes to your physician and says, I have no desire or I have no libido and I would like to be engaging in sex with my partner, you can get a prescription. Is that correct? And that's all it's currently indicated for?
So there's no FDA approved indication for testosterone in the United States of America. No approved, no FDA approved.
Okay.
And we can talk about that's also gender bias.
Yep.
But so even libido is not FDA approved. Why is
Oh,
that? Why is that important? It's important because insurance covers things that have FDA approvals. So it really matters more for insurance coverage than like, can you have it or can you not? People think like it's illegal to give
yeah.
women testosterone. It's not illegal to give women testosterone. There's just so many more barriers to access because of the DEA restriction that there's no female dosed FDA approved product. So any testosterone you do get has to be microdosed or compounded. Oh, and usually it's cash because insurance doesn't cover it.
Right. Okay. Thank
And
you.
so going back to libido, the most common, the most well-known use of testosterone in women is libido. There's actually a global consensus on it. You can Google global consensus for testosterone in women. You can actually pull up the paper and bring it into your physician, which I recommend because it legitimizes, the medical aspect of testosterone. And just to back people up so they understand this, where's libido come from? The brain, right? It's a mood.
Yep.
So thus proving testosterone, we have testosterone receptors in our brain. It helps our moods because libido is a mood that comes from our brain. So and the other thing about libido, just to tell us how wonderfully complex we are, is libido is affected by many things in our life.
Right.
How socially acceptable is it for you to be a sexual person? What did your religion tell you about sex? How's your relationship with your partner? How's your body image? How well are you sleeping? Right? Like that libido is very complex. Testosterone is one part of it. But many people will say when they get on hormone, therapy, whether that's estrogen or testosterone, I feel more like myself. And I guarantee you a woman who feels more like herself feels more like her sexual self than somebody that's like, I don't know what body I'm in anymore, because perimenopause is like challenging that whole thing.
Ugh, I love talking to you, Dr. Casperson. Okay, we're gonna pivot to vaginal estrogen. There's this growing awareness around the use of vaginal estrogen, thanks in part to people like you, among others, sort of understanding and maintaining vaginal health as women age. Can you explain how vaginal estrogen works? Why it might be crucial even for women? And I'm thinking about sort of older 30s now, right? So like maybe entering into perimenopause, not even thinking about it, maybe haven't even heard about it. So even if they're not experiencing significant sexual dysfunction or other challenges in other ways, could you speak about why vaginal estrogen is in fact so important?
Yeah. So vaginal estrogen can come in creams, tabs, rings. Those are the most common formulations. There's a multitude of different products. Vaginal estrogen is very low dose. Think of this like skincare. I call it skincare for down there. And just like I had said previously, we have receptors for hormones everywhere in our body. We have tons of receptors for estrogen in our bladder, in our vagina, in our vulva, clitoris. And most women, they're like, you tell them, you're like, that your labia minora goes away when you don't have hormones. In most women, they're like, what? It's like, yeah, you're going to lose a body part. It might not be a body part that you look at all the time, but it's a body part that's very hormonally sensitive. And so the thing that a lot of women don't associate with menopause, AKA hormone changes, is bladder issues. Yeah. Urinary tract infections, burning with urination, getting up at night to urinate is a very common one, bladder leakage. All of that is because of low pelvic hormones. And you simply, I say vaginal estrogen is a bladder medication, right? You put it in your vagina, the vagina and the bladder share a wall. So most experts will say vaginal estrogen for preventative health at this point. because we really have to switch the paradigm of like, why are you waiting to get sick and have problems to happen before you go get treatment when we know that genital urinary syndrome of menopause, which means issues in the genitals and the bladder that happen because of low hormones. That's what genital urinary syndrome of menopause is. Happens in 50 to 80% of women, if not post-menopause, then perimenopause, that you can have symptoms of low hormones before your periods end, thus proving that the last period is actually not that meaningful as far as when can you start hormones or not.
Yeah.
Advocacy for vaginal estrogen. So vaginal estrogen has an FDA boxed warning on it that says very scary things like probable dementia, blood clots, high blood pressure, scary stuff. It's inaccurate. And we currently have a grassroots petition going on to send letters to the FDA. If Alec could share that, that would be sweet. There's been over 9,000 letters written to the FDA.
Yep.
And this is why it's important. First of all, truth in medicine is important. Facts are important. The risks on the label matching up the science behind it, that's important. The other thing is women who don't have access to the knowledge, they might not know. Because in a 10-minute doctor visit, you can't be like, you're going to read a package insert and it's going to be wrong.
Right.
Keep using this, right? So they'll get the product, they'll read the package insert, they'll think their doctor's trying to kill them, and then they won't use something that's incredibly safe, incredibly effective. And we know, Rachel Rubin did this research. If you put every woman over the age of 65, so Medicare people, on vaginal estrogen, you'll save Medicare $1.2 billion a year in urinary tract prevention alone.
Amazing. I was actually going to ask you about this, and you have said most of what needs to be said, but you did get me thinking, because it's grassroots, how can anyone who comes across this conversation sort of best enter into that grassroots effort in getting this black box warning removed?
Yeah, so it's letstalkmenopause.org, and you'll actually see it under advocacy on that website. And you can just literally click send a letter. So they have two different options. One, if you're a doctor, nurse practitioner, like if you're a healthcare person, you can send a letter from that. And if you're just a lay person being like, you pay for the FDA.
Yeah.
Who does the FDA work for? The FDA works for you. You pay their salaries. It's called taxes. So telling the FDA, hey, I want accurate science on the labels that you make the pharmaceutical companies put in their boxes.
Great.
They made it very, very easy to click and send. And the reason we made it grassroots is because the doctors went to the FDA and the doctor said, please remove this label. And the FDA hasn't done it yet.
Yeah. Yeah.
Because like the FDA doesn't work for doctors.
Right.
Right. The FDA works for you. And so really it's awesome that they created this grassroots, basically letter writing campaign.
Yeah. Awesome. Thank you. I'm going to turn to some questions now for you. Hi, thanks for this webinar. Thank you for being here. I wondered how Dr. Casperson approaches treatment of clitoral atrophy and or loss of sexual sensation.
Yes. I mean, this brings up the point, right? Because so many women are like, I don't want to take estrogen cream. I don't want to blah, blah, blah. And it's like, okay, well, if you don't wear a seatbelt in a car or sunscreen in Texas, like, shit happens.
Yeah.
Right? So,
No, that's so great to kind of point it out like that.
If you don't floss, things happen.
Yeah.
Right. And so it's really like, we know this is a fact. Your hormones go incredibly low and things happen. So why wait for the clitoral atrophy to happen? Why wait for your labia to disappear? Why wait for sex to become painful? Because then you have to reverse all of that if you want to. Right. And so I bring up that in this question of like, in my perfect world, you're not going to wait for your clitoris to atrophy before you're like, how do we figure out clitoral atrophy? Right. Well, we're going to keep the skin healthy and hopefully not have to like undo years of low hormones. So a couple of options for clitoral atrophy. Number one, I love the estrogen cream because you can put the estrogen cream not only in the vagina, but also on the labia minora, that 6 o'clock spot. For people who can see the webinar, but that 6 o'clock spot on the entrance to the vagina gets very thinned and painful. That's where a lot of pain with penetration comes from. I love the cream because you can actually rub it in like skincare, and you can get the cream around the clitoris. And and just target that. You might need a higher dose than twice a week. And if estrogen alone doesn't help, then we also can add testosterone to that locally. And this is a good time to say there's a difference between systemic hormones, meaning hormones that you're using to go into your whole body, and local or vaginal hormones, which is a much lower dose targeted to those tissues. You are allowed to be on both systemic and local at the same time, but I think it can be confusing to people when they're new to this conversation about like the different doses and routes. We tend to do local treatment first for clitoral atrophy and lack of sensation, but we do know that systemically, so higher dose to mean to go into your whole body, both estrogen and testosterone can help with sexual function at a systemic dose as well.
Thank you for that, Dr. Casperson. And just to hover here for another second, for those who are new to this conversation, when you say systemic dose, you were talking about oral, patch, what else versus
patch, cream, gel, oral, injections, pellets, anything that's at a dose high enough where you can actually measure your blood levels as going up because you use the product. When you use local or vaginal, local and vaginal are used interchangeably. I use local a lot because Instagram doesn't like body part work.
No, it doesn't.
Which is awful and another problem.
It is awful. I know I get shadow banned all the time because I hashtag vaginal estrogen or whatever.
So when we say local, we mean pelvic or vaginal.
And that is cream, ring,
tab.
Okay. Thank you for that. Are there hormone replacement options for someone with a blood clot history?
Yes. This is a good point to say. I am not here to offer individual medical advice, but I'm here to get you the info you need to go find your own doctor to get the help you need. Blood clot risk is increased when you take hormones orally. The reason for that is it goes through what we call first pass metabolism through your liver, which increases your clotting factors. Transdermal application, meaning through the skin, does not increase clotting factors. Will you still have a risk of a clot? Yes, because you have a history of a clot. Your risk is higher than the general population, but you're not making it subsequently any higher by being on a transdermal product. You will need to see a menopause specialist or somebody who knows that, because many people don't know that. And again, the labeling on many products is inaccurate.
Thank you. I'm going to take another couple before I get back to some other questions. This gets back to testosterone, and I think this is a good question. It's very clarifying. Should we be taking testosterone? It sounds important. I think, because we're not like infiltrated yet.
It's coming. It's in vogue today.
I know it's in vogue today. Everybody check out Vogue for Dr. Casperson's quote.
So it's this is a complicated topic, right? Because words do matter. And all bodies have testosterone. Testosterone works in the brain and the muscles and the bone and the heart and the clitoris and helps libido in all genders, right? So like universally, everybody has testosterone. There isn't even a product for women on the market for testosterone, right? No expert is going to universally say, just take testosterone, it'll solve all of your problems. It's too many big leaps. So to me, I would say, is testosterone important? Absolutely. But can I make a leap and say everybody should supplement with testosterone? I can't say that, right? And I like to think of it this way. What drug, hormone, product, think of something, do we tell every adult in the world to take? Nothing. Right? Like we don't, in the United States of America, we don't even say all adults should take a baby aspirin. Heart disease is the number1 killer of adults. We don't say everybody should be on a statin. Right? So I want to make people think when they're like, should everybody do this? That's an incredibly high bar. incredible. Everybody means 160 million, Americans, let alone the world.
Right. Right.
Nobody's going to say everybody should be on this. And if somebody says everybody should be on this, they're either on a 60-second Instagram reel, so they have to summarize.
Oh,
but
yeah. Yeah. Yeah.
but it's, do I think it's useful and beneficial? Absolutely. I have women, I see women come back on testosterone and they're like, I feel like myself again. I got my brain back. You'll see in the documentary, The M Factor, me and some of my patients, and taught me talking about testosterone. But I'm one of the most comfortable people with this, and I'm still not going to be out there saying everybody should
Right.
be on this. It's a
Right.
very high bar.
Yeah. Thank you for
And
that.
I'll say, but the healthy woman who is interested in preservation of function should think about, how can she best be optimized and feel great. She might want to consider hormones.
Terrific. Thank you for that. Hi, Kelly. Diane from Florida here. I'm a 54-year-old menstruating woman. My gynecologist prescribed 3 150 milligram estrogen progesterone cream, which improved my joint pain and depressed mood. She warned me that I could bleed more. I'm very grateful for this medicine. However, do I have to increase the amount to get more relief? And will I have even more bleeding if I do? I now have a period every 2 weeks. So again, you can't speak to specifics, but what can you say to this?
So a reminder to everybody, progesterone cream is not licensed and not authorized in this country as a valid way to get progesterone. It's not a valid way to protect your uterus. Remember, everybody who has a uterus, if you're going to take estrogen systemically, you do need to be on a progesterone to protect, not protect. I mean, protect is such a threatening word, just to balance your uterus. Your uterus needs both hormones.
Right.
I hate using the word protect, because it's well, no, your uterus is used to both of them. You just need to give yourself both of them if you're going to be on one. But reminder that progesterone is a very big molecule and it doesn't go through your skin. The amount you need to give yourself to go through your skin to have great uterine protection basically can't be done. So all of the guidelines will say cream progesterone is a no-no as far as safety. We have multiple published studies saying a higher risk of uterine cancer on women on progesterone. Does it help hot flashes? Yeah, because it's a little bit of progesterone.
Right.
And so that's where women are like, but it helps me. I'm like, nobody says it's not helping for hot flashes.
Yeah.
What we're saying is it's not one of the authorized options for uterine protection. And so I always stop with her there. I'm like, I can't even answer the rest of your questions because you're on a product that has not been legitimized by evidence and science.
Terrific. Thank you for that. Dr. Casperson, you were the first person that I heard say, and you said it to me directly, by the way. You said, use it or lose it. Can you talk about what you meant? Because I've heard you say this more than once. What it means when you encourage us with vaginas to use them or lose them.
Yeah. So I would say I'm actually the anti-use it or lose it person. I hate the statement use it or lose it.
What?
Yeah. But and I'll clarify, because there's
Yeah.
always a little bit of truth in the myth, right?
Okay.
So the internet loves the use it or lose it to put on women to be like, you should have sex or something like that your vagina needs a penis for some reason. Because they're not saying use an external vibrator. When they say
No.
use it or lose it, they usually mean put a penis in it.
Right.
That's what they mean.
Yeah, you're right. And that is not what you meant when you said it.
Yeah, and that's not what I mean. And there's no data to support that putting something in your vagina preserves your hormones.
Right.
Or prevents atrophy. Right. And they always if anybody's smart enough to look back at the data, which most people don't, they're lazy and they just say use it or lose it. But I went back because I'm like, where the WTF is this coming from? It's a 1983 article published in JAMA, which is a correlation study. They looked at women with atrophy and women without atrophy. And what they found is the women who have atrophy have less sex. Now, the unscientific person would be like, see, And the scientific person says, like, of course you're going to have less sex if you have atrophy. It hurts. It
Right.
doesn't mean sex prevents atrophy. That's a different study, which nobody's done. Now, where I might say use it or lose it is the better you are at playing pickleball, the better you are at playing pickleball.
Mm-hmm.
The better you are at riding a horse, the easier it is, more comfortable you are riding a horse, right? The more sex you have, the more you're like, I know what turns me on. I know how to have an orgasm. I know what I need. I'm better at having sex,
Mm-hmm.
right? And you will find the people who aren't sexually active getting back into it is it's a little awkward. Just
Sure.
like if you made me go run a 10K right now, I'd be like, oh, I haven't done that in a while, but like the person who ran a 10K on Monday is like, lace up, let's go.
Did you say once, Dr. Casperson, that one of the many benefits of vaginal estrogen is that the vagina will shorten without those hormones? Can you explain that a bit more for those who
Yeah.
maybe still, do I really need this? Do I really need to think about this?
Yeah, so the vagina is elastic, right? That's why we can put babies through it and accept various toys or penises or other things,
Right.
tampons, right? So it's stretchy. It has collagen. It's wrinkly. Estrogen is very important for collagen, blood flow, integrity, thickness of the skin. So when you lose your hormones, again, what do hormones do? Hormones go in cells. They help cells be healthy. That's what hormones do. So you get rid of the hormones, and then the skin thins. You lose your collagen. You lose your blood flow. So the vagina can get shortened. It can get less elastic. It can bleed when stretched. It can become painful when touched. So you're basically just preserving the health of your pelvis.
Okay, awesome. Thank you.
Mm-hmm.
Um, Thank you, Dr. C. Been following you a long time. You were fantastic and essential in the M factor. My question
Oh,
is,
if they
of
saw it.
course, my
I got
question
an early
is about
showing.
DHEA. Shortly after I started my hormone therapy, estradiol patch, and micronized progesterone pill, I started DHEA as well, and my skin went crazy, like a teen breakout. So I decided to wait until the other two settled in to restart. Which would which I would like you, which would I want to do now? Is DHEA my best start for testosterone support? Do you recommend the lowest dose to start? And for how long before women should increase in general? Can you speak about DHEA?
Yeah. So DHEA in America is an over-the-counter supplement. It's a prescription in other countries.
Interesting.
Everything's all made up, my friend. Testosterone's over the counter in Mexico. DHEA is a prescription in Canada. Like
What?
Australia has a female testosterone product. Like everything's made up, which is important for women to know because that means we can change things,
Right. Yeah.
right?
True. Don't be
But
frustrated.
so in America, DHEA is a supplement. What does that mean? It means it's unregulated. Supplements in this country, about 30 to 40% of them don't even have in the container what the label says. So DHEA is very unregulated. I can't even tell you that the product you're taking has DHEA in it. That's
Wow.
the level of trust you get with an FDA approved product is like when it says estradiol at a certain dose, there's estradiol at a certain dose in it. There is a trust in that coming from the pharmaceutical grade stuff. So DHEA, Wild West. The other thing about DHEA is it comes in doses from like 5 milligrams to 100 milligrams. It's a huge range, but again, it's unstandardized. Is this blue bottle's 50 milligrams the same as this white bottle's 50 milligrams? Unregulated industry. So that's my first problem with it. The second problem is the data's mixed. So I think I'm overgeneralizing, but I think perimenopause might have a bigger benefit because you still have the factories that are working, right? The ovaries can actually convert
Sure.
easier. There's less data in the postmenopausal woman and oral. Again, we're talking oral
Yeah.
DHEA right here. The menopause guidelines they don't poo-poo it, but they don't really say that there's a huge need for it. If you're already giving estrogen, progesterone, and testosterone, you're going to be hard pressed to find some legitimate paper to say you need to be on DHEA. If you take it and you love it, great. It probably isn't hurting you, but it's kind of Wild Westy. And now I will say, but DHEA in the vagina which is a standardized pharmaceutical product. It's called Intrarosa or Progesterone. It's DHEA, and it's in a suppository that goes in the vagina. That's a beautiful medication. It works fantastic for genitourinary syndrome of menopause.
Okay.
Again, I know what you're getting when you purchase that product because it's actually a pharmaceutical grade product. And it works very well. The biggest problem with it is it's pricey.
Yeah.
But I love it. If you said, if Rachel, if you said, Casperson, I've got a tube of vaginal estrogen and I've got DHEA suppositories and I'm going to give them to you for the same price, what would I pick? I'd pick the DHEA because
That's so
that's going to convert to a little bit of testosterone,
testosterone.
which I know the pelvis loves, right? But I can get a tube of vaginal estrogen for very cheap, and vaginal DHEA is still quite pricey.
Thank you for that. That's so helpful. What do you do? What do you recommend as a treatment for no libido if you cannot get testosterone?
My book,
You are not
you're
broken.
not broken.
You are not broken.
Stop shitting all over your sex life. Libido's complicated. So the
Yeah.
first thing that you need when you have no libido is get educated about libido.
Yeah.
Number one. And in that education, you will understand everything affects libido. And it's not just testosterone. It's not just estrogen. It's not just your age. It's not just, it's libido is incredibly complex. The other big myth about libido is that it should be spontaneous or you're broken. That's not true. And the other myth is that you shouldn't have to do anything to like get turned on or be sexual. Is like, yeah, absolutely you do. You got to warm up to be in the gym. You got to warm up to
Right.
have an hour of sex. So we didn't get good adult sex education. So we believe everything Hollywood tells us, right?
Yeah.
You should just be hot and ready to go all the time. And you should want sex all the time. And nothing should affect that. And you're broken if you don't have that. That's what Hollywood tells us, right? Hollywood's wrong. That's a curated, planned story they're giving you. So the first thing you need when you have low libido is education about libido. And then you go from there. But I have saved marriages with this book. I've actually ended a marriage with this book because somebody was like, I realized that I'm worthy of love. Right? So the amount of education, we have this information now. It just doesn't trickle down and people feel horrifically broken. They don't understand libido, they don't understand sex, and they think the answer is just in a hormone, where it's like hormones are great. Hormones are great. And they can be helpful. But if you just throw on a hormone and you don't have that education, you're not going to get the full benefit.
So, Dr. Casperson, then would you say that sort of the biggest barrier to preventing women from fully, I guess, enjoying their sexual wellness is lack of education about what that is?
Oh, yeah.
Yeah.
Totally.
Yeah.
Women get educated and they get empowered and they're like, oh, sex is for me? I was raised to think sex was for somebody else.
Right.
I was doing it to keep somebody else happy. I was
Right.
having sex the way somebody else wanted to have sex.
Right.
They take this like advocacy, empowerment lens and they're like, first of all, what have I been doing? Second of all, why is society so shitty to women? Right? Like you get some education and you're like, oh, this is rough. I've just been having sex the way somebody else has liked having sex my whole life. Right.
So, Dr. Casperson, just before I turn back to questions, I'm imagining you in your practice before you've written a book, before you had a podcast, the rumblings of advocacy happening. What was it? Was there a moment? Was there a collection of patients that came to you for help that kind of made you say, enough. I'm stepping into this and I'm going to shake it up.
Yeah. Yeah. I mean, my origin story was a patient I was very bonded with, right? Because it takes that. You can't be some stranger. I'm sure strangers change people's lives too, but like I was very bonded with this woman and she came in with a sexual health issue and I didn't know how to help her. And so I was like handing her the box of Kleenex as she's crying. And in my head, I'm like, does anybody know? Does anybody know how to help these people? Like, because I was just told women are difficult and challenging. The
Yeah.
gynecologists are taking care of them, so don't worry. Because remember, I'm a urologist. Like, I'm
Right.
not a gynecologist. But I'm like, we give Viagra to the dudes. 90% of men are heterosexual. So who's taking care of the people I'm giving Viagra to? Who's taking care of their partners?
Mm.
Right. And I really started learning to be like, well, I'm going to see if it's true that nobody knows anything. And it turns out we know a lot. It just doesn't trickle down, right? It doesn't even trickle down to the medical schools where the doctors are going to learn,
Right.
let alone, somebody who doesn't know what a clitoris is, right? Because
Yeah.
when my sex ed in 8th grade was like ovaries and uterus, that's how babies are made. Like, we didn't learn about vulva or clitoris. Instagram doesn't even let us say our body parts. Like, that's how messed up this is, that we're not
Mhm.
even allowed to say our body parts. So yeah, does education go a long way? 100%.
Thank you.
Totally.
Um, Bad GSM, vaginal tears, itchiness, burning,
Oh,
nocturia, dryness, etc. And currently using daily bag estrogen, or I'm not, is that
probably vag estrogen.
okay. Only on the outside. Is that okay? I'm 98% better ever since I started daily use, but I'm not sure if using daily, if it's dangerous. So she's using vaginal estrogen only on the outside. Is that okay?
Why
And I'm,
not?
I'm
I mean,
90,
you gotta get it in the vagina for it
gotta
to
get
help the
it.
bladder,
Yeah.
because
So
the
tell
bladder
us
and the
how
vagina share a
how
wall.
how should people be using vaginal estrogen cream?
Yeah. I mean, I always want to know, I think it's individualized, right? Are we
Okay.
doing it for prevention? Are we doing it with our goal to treat a symptom? Or
Okay.
if it is for a symptom, what symptom do you want to treat it as? So, I mean, that's why it's so individualized
Yeah.
of like, there's not a one size fits all. I mean, I can tell you how to put vaginal estrogen in your vagina, but if you're sexually active, put it on your vulva too, right?
So this person is saying that she's 98% better since she started daily use. Is
Amazing.
daily use safe?
I don't know how much she's using every day.
Okay. Okay.
But,
Thank you.
right? Like,
Yeah. No. These
that,
are
this is why you have to see an expert, because it's like, are you using a pea-sized amount? Are you using 2 grams? Do we need to worry about your blood levels going up? Probably not, because we know systemic estrogen's safe, right?
right.
So it's probably safe, but again, she didn't tell me her dose.
Okay. Okay.
And just to remind people, doses matter.
Yeah.
That's why, because people are like, what's the difference between systemic and vaginal? Dosing.
Dosing.
So if you dose vaginal high enough, you'll get systemic dosing. That's more likely with daily use.
Okay. Thank you.
Yeah.
Dr. C, can you speak about lichen sclerosis and how hormones might help? Thank you for this
Mhm.
question.
So lichen sclerosis is an autoimmune condition of the skin. It causes thinning, itching. It's actually way more common than we think it is. Very rarely, lichen sclerosis can convert to vulvar cancer, so it is recommended to get exams. Um, Estrogen just, again, helps in the quality of the skin, helps with blood flow, helps with collagen, helps with, cell health so cells can function. So I kind of always cringe when I see a woman being treated for lichen sclerosis who isn't also on a pelvic estrogen, because I think they're very complementary. Because even if we take away your lichen sclerosis, you probably still have GSM.
Right.
So it's like we want to treat both of them. It's a myth. The lichen sclerosis experts will disagree that there's more in low hormone states. Some people will think there is more lichen sclerosis in low hormone states. Not all experts agree on that. But again, it's not that we don't think it's the lack of hormones that causes lichen sclerosis. It's more likely an immune, condition. But the
Um,
treatment for lichen sclerosis is local dosed topical steroids, most commonly clobetasol, which is a stronger steroid. Again, local. It's not a pill of steroids that you're swallowing. Still very, very safe product.
Thank you. Dr. Casperson, someone actually DM'd me a question.
They got
Uh,
access to Rachel.
yeah, I provide direct access.
That, my friends, costs extra.
Yes. Um, and she said, you keep it real in your book about orgasms and pleasure. Why am I not having an orgasm? Do I need vaginal estrogen to achieve orgasm? I'm confused about this.
Yeah, I mean, I don't think you need vaginal estrogen to have an orgasm. Does it help? Absolutely. Helps nerves, helps blood flow, helps things not hurt. Orgasms are multifactorial. Is it a medication that you're on? Is it systemic hormones that are low? So, because remember, systemic hormones also help sexual function.
Right.
So it's not just a local vaginal estrogen. If somebody came into a doctor and said, I don't have orgasms, and the doctor's like, here's some vaginal estrogen, like it's the tip of the freaking iceberg.
Right.
Like, what are you thinking about orgasms? Are you focusing on the clitoris? Have you ever had an orgasm in your life? Did you have great orgasms and then they stopped? Maybe when you got a back injury. Is there a nerve thing we have to look into? So I would say medicine and sexual medicine with orgasms is not as well developed of a science as like how to treat GSM.
Right.
Or even how to treat pain with sex. Like that's more advanced than like helping women with orgasms. There is going to be orgasm guidelines coming out.
Really?
I would love to say 2025. I don't know. I'm not writing them. But they are currently working on consensus best practices for orgasm dysfunction. So that's going to be great. Many women I talk to who are on systemic testosterone do say that the orgasms are, I want to say the word easier, but like better facilitated
Okay.
by being on systemic testosterone.
Mm-hmm.
So yeah, orgasms are complex. And
I'm
remember,
good.
it goes back down to sex ed, right? Like so many women feel broken because they put something in their vagina and they don't have an orgasm. And it's like 70% of women don't have an orgasm by putting something in their vagina.
Right.
So
Right.
that's a question. Like, how are you trying to have an orgasm? Are you comfortable with masturbation? If not, why not? Let's explore that. Like sex is
It's
so
big. It's
it's
vast.
wonderful because
Yes.
it's
Yes.
big and it's like a bowl of spaghetti. You're like,
Yeah.
it's
Pull this
not.
thread. Pull that thread. Yeah.
Yeah.
I love
And
that.
so to me, I'm like, when a person comes to me with orgasms, I'm absolutely thinking about she needs a good pelvic exam. Does she have clitoral phimosis? Does she have GSM? Does she have pain when she's touched? What are her hormones like? Right. So that's what the does she have a back injury, hip injury, pelvic injury? Like that's what the physician's thinking about. But then we need the sex therapist and maybe even a physical therapist, especially if there's pain.
Right.
What's going on with all of that. So sex is biopsychosocial. You probably will need more than just a physician to work on orgasm.
Amazing. Thank you. Um, Discomfort in the labia while having intercourse. The pill insert is not helping. Does vaginal estrogen cream help with that discomfort?
Again, discomfort is 100 different things.
Okay.
Right?
Mm-hmm.
I like again this does bring up and always like an opportunity to discuss my cream bias.
Tell
So
us. Tell
I
us.
like the cream because it gets on the vulva.
Yeah.
It gets on that tricky 6 o'clock entrance spot. You put it on your labia minora and preserve it. You put it on your clitoris to help preserve the function. And I just think the Vagifem tabs are very low dose and they sit in the vagina and they just don't have the chance to treat the vulva. So also the cream tends to be the most inexpensive product for most people. So again, I have a cream bias. I would have a vaginal DHEA bias if I could get the price to rival.
Right.
But I'm planning on being postmenopause for at least 40 years.
Yeah.
And cost matters.
Yeah. 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 Thank you for that. There are several questions about, and I'm sort of putting them together for the sake of this conversation, but um, really, I guess if you could just kind of home in one more time on um, sort of understanding dose of vaginal estrogen, how to know kind of if you're in your sweet spot or not. Is there sort of like I've heard people talk about kind of onboarding vaginal estrogen, using it daily for up to 2 weeks. Some people say
Yeah.
6 weeks. Can you
So
talk?
I've not seen any data as to why somebody needs to daily dose to start.
Okay.
I cannot dig it up. I've asked pharmacists, I've searched the literature. It's made up. Like
Okay.
from
That's
what
so
I
good
can
to
tell, the
know.
loading dose is made up.
Yeah. All
And
right.
this is why I don't like the loading dose. Usually you're coming to me because you have a problem. You already have atrophy, you already have pain, you already have low hormones. You're usually not coming to me to be like, I'm 45 and I want to keep this going, right? Which I love when those women come because it's freaking fun. But
Yeah.
usually you already have low hormones, your skin is thin. And if I give you a product that is daily to that skin, it's too thin and it's going to absorb a bunch of it. And then you're going to come back and you're going to be like, my vaginal estrogen gave me headaches
Right.
and tender breasts, and I hate this. And you said it was local, but I
You
feel
like,
it up here,
yeah.
right?
Yeah.
And so it's like, yes, until your skin gets its integrity back. Remember, skin's job is to be a barrier. But when it gets thinned, it can't do its job. So it'll soak up a bunch of the hormone. So to me, I'm always like, I want to start you at a standard dose. I want to idiot proof it because it's a lot to go to the doctor. And then you're like, she said to use it daily for how many weeks? And then how many times for how many weeks? Like, it's too confusing.
Mm-hmm.
It's like twice a week, 1 gram. That's the standard vaginal estrogen dose. See where you get in 6 to 8 weeks. Takes that long to improve skin. And then we can always go up. But I'd
Right.
rather you not have side effects and see a benefit than have side effects and be like, and the label says it's going to cause dementia.
Yeah.
Look at the scary thing. Like they swear it off then. And I'm like, you'll be back in 8 years.
Yeah.
And you'll tell me vaginal estrogen didn't work the first time. Right.
Right.
And so I'm like, I want to set people up for success.
Yes. Say more
Simple,
about that.
yeah, simplify it, keep it inexpensive, give them something the hardest part about twice a week, again, is remembering the days to use it. So I joke, I'm like, whenever you floss, because that's usually twice a week for me.
Yeah.
But
I,
that's not how everybody
if
flosses.
you floss daily, maybe
That's
take
a
it easy.
problem.
Yeah.
But yeah,
Yeah.
then you have to think of something else like twice
Set
a
an
week.
alarm. Set an alarm.
Yeah,
Um,
Sunday and then garbage day. I don't know.
yes, there you go. Whatever works for you.
Whatever works.
Dr. Casperson, is there anything I've sort of left out, not giving you room to bring home to us for us?
Use lube.
Yeah, use
Like
lube.
the
We
non
can,
the non-hormonal vaginal moisturizers and then lube for intimacy. They're like they're universally pretty darn good products. I like for my bias for perimenopause, postmenopause for lube, again, for sexual lubricant, not a daily moisturizers. They've got great products too. But I like silicone based. I like oil based. It's not tacky. It's not cold. Um, Caution oil based if you use condoms. Um, but I just like those products because if you have thin skin, dry skin, sensitive skin, they just last longer on the skin than reapplying a kind of a tacky water. I don't mean tacky like cheap, although they're cheap. A tacky like the consistency is not as like
right. Not as sweet and divine.
not as luxurious of an
Not
experience.
as luxurious. I love it.
Like to
Yeah.
me, I'm like, this is what when you want it, when you think of it as a pro tip, when you think about cultivating like the sex life that you want, like yeah, it's harder sometimes to think about what you want because you don't know, you don't have that good sex.
Right.
But you can think about what you don't want. I don't want to be cold. Right. So for me, like water-based lube, I'm like, ugh, I don't want to be cold.
Yeah. 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 That's important. That's so important. That's so
So
good to
that's a pro tip of like, if you're like, I don't know how to have a great sex life, okay, do the opposite of what you don't want.
That's a perfect start.
Right? Like be relaxed, have lube that's nice, be warm,
Yeah.
don't
Yeah.
rush it.
Yeah.
All the intro 101s.
All right. Um, Dr. Casperson, thank you.
Yes,
Thank
yes.
you for all of your advocacy. We all who have not yet seen the M Factor look forward to seeing you in it. Truly, I mean, thank you for all that you do for all of us and will continue to both on legislative floors, in conversation. Um, Thank you for this conversation. I absolutely always
Thank
love
you.
to speak with you and see you. Thank you all who came today. I just want to lastly throw out again to to encourage those of you here to take advantage of that code on myalloy.com. It is Casperson 20. And I encourage you, connect with somebody who knows the science as you need them to know it. And that is so often, more often than not. Well, I have to just say this, I'm derailing a moment, but I have to say urologists were the first physicians that I had conversations with who knew this part of the conversation like no other.
Yeah, I mean, there's a lot of hormone experts that can't work their way around a vulva.
That's right. That's right.
For sure. But
That's
I mean,
right.
there's also lots of urologists that can't work their way around a vulva.
Yes.
The role of a good pelvic exam, it's easy for me to be like, go get a good pelvic exam. But like, that's a big ask. Not everybody is trained in that.
Right.
So yeah, like really, and I say that to be like, even people who are menopause experts aren't pelvic health
Right.
experts, and vice versa, right?
Right.
But like the urologists who treat sexual dysfunction, like we have to be hormone experts because
Yeah.
the pelvis is so hormone sensitive, and when you take those hormones away, shit happens.
Yeah. And until then, do speak with a menopause specialist like
Yes.
those we offer at Alloy. Thank you, Dr.
I mean, Alloy does such a good job because Alloy combines, sexual health, menopause, pelvic health, like it covers it, which is
Our doctors really get it. Yeah. And we have a deep bench of doctors who have done that extra study so that they can help those.
Yeah. And I mean, I don't think I've said anything today that the Alloy team would, like, everybody's kind of on board with the 101 we just did.
Absolutely.
Yeah. So it's like, that's what's so nice is like, you're going to go to a place that's receptive versus listening to this Alloy and then going somewhere where you're like, you might have to educate them.
Right.
Alloy's already educated.
Certainly we are. Thank you, Dr. Casperson. Be well. Good to see you.
Thank you.
Bye, everybody. Thank you so much.
Everybody.